contraindication to ECMO or any other bleeding complication for that matter. Neonatal, in our neonatal populations, we'll usually see many times a combination of all of these. Congenital diaphragmatic hernia, you'll usually accompany with PPHN. A lot of times we'll see air leak syndrome as a result of trying to ventilate these patients. And meconium aspiration, these are the simple ones. You put them on an ECMO pump, and after a few days, the meconium just goes away, and you don't have any lung injury. But usually you'll see a combination of these three. This one's the most complex. The idea is we put them on ECMO, and the smooth muscle that surrounds the pulmonary vasculature is constrictive. It's not allowing the blood to flow through the lungs. And so the idea is we give them some, what we like to call IV oxygen. We allow that smooth muscle to relax. And the hope is after about 2 weeks, that smooth muscle is atrophied. And then when the kid is put back on the ventilator, the smooth muscle doesn't constrict, or doesn't constrict as much. We usually know within 2 to 3 weeks of ECMO whether or not we take them off, whether or not they're going to survive or not. It's either we can make the muscle atrophy or it's permanent. In that case, it's usually lethal. Contraindications. I have come to learn that there's no such thing as an absolute contraindication. We've cannulated people that I thought no way in heck we're going to put this patient on ECMO. I've cannulated people that I thought no way, and some of them have survived. But these are some of the ones that are pretty clear. If you've got an incurable malignancy, we're probably not going to alter that outcome. Same thing for advanced multi-stage organ failure. If you're in kidney failure, liver failure, lung failure, cardiac failure, that's pretty much 100% failure. We're probably not going to fix all those problems. Extreme prematurity, we have a limit in size. We can only cannulate kids that are greater than 2 kilograms. So the little tiny babies, they may have lung and or heart issues, but we just don't have tubes small enough to fit in them to provide support. Severe head bleed, we're probably not going to alter that outcome as well. We do make special considerations for non-transplantable cases. There are some centers that are utilizing ECMO as a destination therapy, but it's in-house, and it's basically what we talked about before, giving that family a time to reach a decision on when to withdraw support. So pulmonary management on ECMO. I want everybody to repeat after me, lung rest. Lung rest. This is the point of what we're going on ECMO for. We're going to take the burden of doing gas exchange and give it to this artificial oxygenator. We no longer need the native lung to do that. So what are we going to do? And this is where you guys come in. We need you to be helpful advocates, because many times our residents don't necessarily understand. They're so used to managing the ventilator for gas exchange that we need to kind of take that thought off their mind. So what we're going to do is we're going to start off minimizing the FiO2, try to prevent the high oxygen lung injury. Decrease PIP, or in many cases the distending or driving pressure, and plateau pressure. Get those down so that you're not actually exacerbating the lung injury in these patients, many of which have ARDS. Attempt to decrease the work of breathing. This kind of dovetails into Dr. Dorshug's talk quite a bit. He talked a lot about ventilator asynchrony, and that's an indication of work of breathing and can actually cause lung injury. So we're going to try to stop that, utilizing a lot of the strategies he talked about. One of the numbers that I'd like you all to kind of start looking at is that work of breathing. It's in the spirometry. I believe it's on page 3 on the side of the servo. I don't know about other ventilators. But this number is the amount of pressure that's generated in the first tenth of a second of a spontaneous breath. And we want that number to be as low as possible. If the patient's really working, and you can see it when you're looking at your patients, you know, they're using accessory muscles and they're huffing and puffing. This number can be 13, 14, 20s. That's extreme work of breathing. And we want to try to limit that because the patient's actually causing lung injury to themselves. You can utilize any mode in ECMO. The idea is to keep in mind all of these concepts up here. Peak pressure, distending pressure, driving pressure, plateau pressure, whatever you want to call it. Let's decrease that and decrease the patient's work of breathing, which involves assessing your patient. It takes a lot of collaboration between the ECMO specialist, the doctor, the respiratory therapist to figure out what's the best mode and settings for each individual patient. Diuresis. We're going to try to pull off some fluid off of these patients. And CRT, we can actually hook the CRT circuit directly into the ECMO circuit. And so it's a very simple way to pull off fluid. Like I said before, that initial 24 to 48 hours, patient's going to have what's called a SIRS response, a massive body inflammatory response. And when we're doing that, we're having to pump a bunch of fluid into them to keep that ECMO pump rolling. Well, they end up almost always, fluid overloaded. And so one of the ways we combat that is we hook CRT or dialysis machine directly in line and get some of the fluid off so that their lungs can get better. Pulmonary toilet and suctioning. I will caution on this. We want to be careful with our suctioning. We don't want to sit there and shove the suction catheter all the way down and start banging on the carina. Many of these patients are heparinized, so that could start a pulmonary hemorrhage. But in general, you need to suction because they're going to have a fair amount of secretions as the healing process is going on. And bronchoscopy. Get an idea of what's actually going on with the lung and possibly suctioning out some of the stuff that's deeper. Extubation. We do extubate our patients, especially our adult patients, on ECMO. Sometimes the best way to prevent lung injury is to remove the positive pressure. Not all patients can tolerate this. Some of them who have profound lung injury just require pressure. They require PEEP, usually specifically. But some of them can be extubated. It's kind of crazy seeing an ECMO tube in somebody's neck and no tube down their throat. But a lot of them tend to do okay. If they don't tolerate extubation, sometimes we have to move to early tracheostomy because their pulmonary rehab stint's going to be pretty long. So early tracheostomy is a key. And like I said before, don't attempt to recruit the lung in those first 48. You're dealing with that SIRS response initially. ECMO actually exacerbates that early on. Blood touching plastic isn't a good thing. The body doesn't like it, and it releases lots of bradykines, cytokines, histamine, things like that, which causes fluid to leak out of the vessels and into the tissues and into the lungs. So your lungs aren't going to be recruitable within the first 48 hours of going on ECMO. And then after that, we can start maybe doing some lung recruitment strategies to try to improve lung function. How do you determine adequacy of support? Well, blood gases, obviously, and make sure that we're kind of within our parameters, although our parameters on VV ECMO are going to be a little bit different than what you're used to. We'll look primarily at our venous oxygen saturation. The blood that we're returning back usually shows how much, what we're delivering and how much of that is being consumed. Lactate, big determinant. If your lactates are rising, you're probably not perfusing the tissue with enough oxygen. And in VA, what's our blood pressure? Well, once again, you know, we tend to occlude what the systolic and diastolic numbers is, so we look at the map a lot. And then the easiest thing, you just want to cover up that monitor and tell people, okay, look at your patient. Do they look okay? Are they pink and dry? Or does it look like they're perfusing? And sometimes that gives us a better indication of how well we're supporting the patient. So blood gases. I know we have our own blood gas lab in PICU, so you guys are very familiar with these, but we draw 3 of them when we're on ECMO. You draw pre, post, and patient gas. The patient gas is fairly obvious. That shows what we're perfusing to the tissue. The pre-oxygenation gas is the gas we draw before the blood enters the oxygenator. And the post-ox gas is what we draw after the blood has gone through the oxygenator. And what we're looking at that is we're trending it to what the patient CO2 and what the pre-ox CO2 is. So are we ventilating the patient well enough? And then we look at those 2 gases comparably together to see if that oxygenator is actually functioning. People familiar with ECMO before, our oxygenators used to clot off. And an indication of the oxygenator clotting off, we used to look at pressure pre and post. With the new oxygenators now, that's usually not the case. They don't clot off. They will stop doing gas exchange long before they clot off. And so this is a much better indicator of what the functionality of our oxygenator is. So that's why we draw those 3 gases. Oh, I don't want to log on. So with all that information, you guys are experts now, right? Let's look at a patient. This is a 70-kilo patient, so obviously an adult. It might be a larger peds, but on VV ECMO. So we've got a double lumen VV cannula. on rest vent settings, whatever those might be for you. Well, we can discuss that as well. Pump flow is at 4.2 liters. That's pretty common for an adult. Sweep gas is at 8. FiO2 is at 100%. And here's our gases. This is what we're getting back for the patient gas. This is our pre-oxygenator gas and our post-oxygenator gas. So I guess the first question I'll ask you guys, and these are kind of some of the parameters you're looking at. Does it look like our oxygenator is functioning? Probably. That number right there is pretty good oxygenation coming out the backside of that oxygenator, so it's functioning pretty well. Does it look like we're clearing CO2? Those two numbers. 17 points. We usually, 10 or less, we start to get a little concerned. Anything above 10 is usually pretty good. How do you think we're supporting our patient? Do you think we're adequately supporting our patient? Will we change anything? How do you feel about those numbers? What do you think about that pH? A little on the low side, but not terrible. We've obviously, if we're in critical care medicine, have seen a lot worse than that. How about our CO2? What do you think that is? Normal? Maybe a little high? Maybe a little high. How about your oxygenation? Your SATs are 84%. Your PO2 is 45. Is that okay? I want you to get used to this number because a lot of your VV patients are going to be sitting right there the entire time they're on ECMO. We have to kind of retrain ourselves. We've dramatically altered our physiology. And so a patient satting 84%, obviously we're missing some information here. We haven't assessed our patient, but I always say, people call this the popsicle test. If your patient's sitting up in bed, they're pink and dry, and they're sucking on a popsicle watching TV, this is probably okay. They're not in distress. So we're supplying enough oxygen to their tissues. We can see SATs all the way down into the 70s even sometimes. The key is going to be our SpO2, which isn't listed here, and our lactate. Once again, are we providing enough oxygen to the tissues so that we can bridge the patient? We're not going to achieve ideal. You're not going to see a VV patient with a 99% oxygen saturation just because of the mixing and the lung disease. So we're going to have to, my favorite type of good is good enough. This is good enough to support the patient. I might consider going up on our sweep. Once again, we're not going to alter the ventilator settings because the lungs aren't doing much of anything, aren't capable of it. So we're going to go up on our sweep, probably. Get this CO2 maybe down into the 50 or low 50s, upper 40s, and that'll kind of normalize our pH. But that would probably be the only change I would make, as long considering that obviously the patient doesn't appear to be in distress. VA physiology. VA physiology is a little bit different because we're returning the blood to the artery, so you're going to have some different things occurring. You've got native cardiac output to consider competing with pump cardiac output. So that's the other thing. And then the cannula position. Where's the cannula position in the body? Is it a femoral cannulation, a carotid cannulation, a central cannulation? So we're going to look at a couple of videos here. Mayo Clinic was nice enough to put out some videos to show what's going on with these different cannulations. Is that coming up on there? No. Yeah, what's coming up here is not coming up there. I mean, it popped up there, but it didn't come up there.
Look fast.
One more over. One more up. 47, I guess. Do we have to minimize the slideshow? Oh, we got audio. It really is showing it. Go ahead and hit pause. 2 monitors. Sorry, slight pause. Discuss amongst yourselves.
You have the video up here where you can sit.
Yeah, you're right.
Okay, now grab this.
There you go.
There we go.
Mike to the rescue.
Bam.
Yeah, okay.